Thank you. Good evening, everyone. Welcome to tonight's meeting of the Health and Social Care Scrutiny Review Group. I'll just do the administrative stuff first. The meeting will be live streamed to the public, and a recording of the public part of the meeting will be available on the Council's website within 24 hours. If participants joining remotely, can you use the hands up icon to indicate that you would like to ask a question or make a comment? Turn your camera and microphone on when speaking and off when finished. Would members and officers please remember to switch their microphone on when speaking and off when they are finished speaking, and speak directly into the microphone if you are in the chamber. Anyone in the chamber, please switch off your mobile phone or place on silent mode. Okay. Do we have any apologies for absence?
None, Chair.
Okay. Minutes for the meeting of the 22nd of October 2024. Are they a true and fair reflection of the proceedings of that meeting? Yeah. Thank you. Any disclosures of interest?
None that I'm aware of, Chair.
Urgent business?
Then none, Chair.
References from committees or other bodies?
None, Chair.
Thank you. Okay. I have a couple of things to update you with. At the last full council, we passed a motion concerning the East of England Ambulance Trust plans to close the Bedford Emergency Operations Centre. Part of that motion was a clause asking the trust to report to this group sometime in the future. And it looks like they will be attending this meeting in January. The other item is the plans for the relocation of the Mount Vernon Cancer Centre. I attended the initial meeting of the Joint Scrutiny Committee to overview that relocation. Some of the new members might not be fully up to date with the issues involved in this. The centre is located in the northwest of London near Rickmansworth, provides non-surgical cancer treatment to patients from counties to the north of London and some north and west London boroughs. 2023, about 700 Luton residents made over 9,000 visits to the centre. And for various reasons, that centre needs to relocate. The proposed new site is at Watford General Hospital. There will be facilities to administer radiotherapy and chemotherapy at the new site. My understanding is that funding is in place for the new site. There is also a proposal to decentralise the radiotherapy service. A new radiotherapy site will be set up at either the L&D or at the Lister in Stevenage. The Joint Overview Committee is planned to meet 4 times over the next few months, with each meeting dedicated to a separate theme, for example, transport provision to and from the centre. The MVCC are conducting a consultation exercise at the same time as these meetings of the Scrutiny Committee will be taking place. It's important that the views and needs of Luton residents who use the centre are taken into account when any decisions are made about the future service. And it's important that the views and needs of Luton residents who use the centre are taken into account when any decisions are made about the future service. To that, and I will be working closely with Democratic Services and also the BLMK to that end. Okay, and if anyone has any questions about either of those items, please let me know. Okay, we move on to item 7: improving resident experience of access to primary care in Luton. Is Amanda online?
I am, yes. Thank you. Good evening.
Okay, want to go ahead?
Thank you. Just bear with me 1 minute, please. Apologies. Good evening. Apologies for the delay. Sorry to keep you waiting there. Thank you for inviting me to join your meeting. I'm here this evening on behalf of Nikki Pillane, the Chief Primary Care Officer of BLMK ICB, who unfortunately has not been able to attend. And my name's Amanda Flower, the Deputy Chief Primary Care Officer with the ICB. So I'll take the paper as read, and I'll just highlight to the committee this evening some aspects of the report that I think are helpful. So the paper presents to you a summary of how we are trying to improve resident access of primary care, and it describes the 5 components of primary care as general practice, community pharmacy, dentistry, optometry, which is limited to site tests, and integrated urgent care, which people will recognise as the 111 service, and GP out of hours, which is the primary care service that residents can access when their general practice team outside core hours is not available. So what we've described for you is a 24/7 offer of primary care. And if I just touch on some of the activities that we've included in the report and highlight those for your attention this evening. Back in October, we ran a successful NHS app focus day in Luton with the aim of encouraging residents to utilise the NHS app. While we accept and understand there are some constraints for some residents in using the NHS app, it does have benefits. It does allow residents to order repeat prescriptions, and it does allow residents to access their health records. And in the context of digital first, we think that if we can encourage the population to use the NHS app who are able to, it supports other members of the population to be able to access services in different ways. So essentially trying to keep phone lines free for those who are not able to use digital offers such as the app. We go on in the paper to describe the Pharmacy First service. Pharmacy First was launched in January this year, and we've had a really positive response and uptake of Pharmacy First in Luton. We've got the highest number of consultations being accessed in Luton through the Pharmacy First service, and we've detailed in the paper the 7 pathways or conditions that residents can access from their pharmacy. They can be referred, or they can walk in and access those essentially as a self-referral. We really want to drive with residents to utilise community pharmacy services where it's appropriate to do so, because that again frees up access to general practice for complaints and issues that really need the expertise of that practice team. We go on in the paper to describe the modernisation work that we're taking with our practices in Luton, and we call that modern primary care access. Typically, residents will be familiar with what's referred to as the 8 a.m. scramble to get appointments from your GP practice. And what modern practice access intends to do is embed a triage approach so that clinical need is assessed. And this means that on the day that residents contact their practice, they know how their complaint will be managed. And that can be that the patient or resident is supported to self-care, is signposted to a more appropriate service, which may be what I've already described, the offer available in a community pharmacist, or is given an appointment to see a member of the primary care team. We now have 13 practices in Luton delivering a triage-based modern access model. And early feedback from residents is positive, with appointments being made available throughout the day at those practices that have gone live. We are working hard with the remaining 10 practices in Luton to mobilise, and it's a requirement of the GP contract that by the 31st of March 2025, the practices are delivering that modern access model. We go on in the paper to describe the 111 services, and as you'll have read in the paper, we've described a period of high demand for 111 services. which in turn saw a reduction in their performance or the speed at which calls were answered. And we know that this leads to frustration for residents and can mean that residents may go elsewhere to access services. We've been working with our 111 provider, who is Hook for Luton, in terms of how they improve and stabilise the position. We have seen some reduction in call volume to Hook, which has really supported that stabilisation. And we're now seeing a much better response rate to calls. And we think this is in parallel to the work that I've always described in our practices, delivering that modern access model. In the paper, we have also described the work that we're doing with dentistry since the ICB took over, if you like, the responsibility for dentistry from NHS England, which is about a year and a half. We took that over in April 2023. And the paper sets out a number of initiatives that we've been trying to do to improve resident access to dentistry. We've implemented several initiatives which are described in the paper, which includes a patient premium, a recruitment incentive scheme. We're increasing pay rates for units of dental activity for some practice. And through the dental access pilot, we're providing access to urgent dental appointments out of hours. And we're continuing to use the flexibilities that are provided to us as with our responsibilities for dentist commissioning to try and improve access to our population. We've seen an increase in the units of activity of dental care delivered to the population in Luton year on year, and the early indications that that is continuing in this financial year. So I'll stop there as a summary of the paper. I'm very happy to take any questions that the committee has in response to the paper or anything I've said this evening. Thank you.
Thank you, Amanda. Okay, yes, I'll throw this open. Councillor Nasser had a hand up first.
Hi, Amanda. I've got a couple of things actually. I just want a clarification about you said about the modern general practice. 13 has been working already, and 10 implementing remaining. But does that mean we have only 23 GP surgery? And I've got second thing I want to know. I don't understand about that one. The ARRS post. What can you explain their role? I've got a couple of things. I just want to understand what is the difference between primary care dental contract and community dental contract. Yeah, thank you for that.
Okay, so I'll take those questions in turn. So yes, we've got 23 practices that we've reported in the paper. We've got some practices. Essentially, practices were given a 2-year window to mobilise modern general practice access, and they were asked to do that ultimately by the 31st of March 2025. And as an ICB, we've been working with practices to support them through education, and they also have access to some transformation support to help them on that journey. So as I've said, it is a requirement of the contract for all to deliver by the 31st of March 2025. So future updates, we should be able to report the full progress of the practices in Luton. Your next question with regard to the additional role reimbursement scheme. The additional role reimbursement scheme is part of the Primary Care Network DES, and this was introduced 5 years ago now, and provides funding to primary care networks to recruit wider ranges of multidisciplinary teams into general practice. So we've seen clinical pharmacists, first contact practitioners who are MSK specialists. We've seen health coaches, care coordinators, social prescribers appointed as part of those additional roles. So primary care networks are given an allocation to spend on these additional roles. And what we do as an ICB team to ensure that we're driving the use of that funding that is available. We support our PCNs with their recruitment and retention initiatives. And what we've seen actually in our access numbers in BLMK, and this is consistent for Luton, that approximately 50% of appointments delivered in general practice are now delivered by roles other than a general practitioner. So whilst the general practitioner is the lead of the general practice team, it's really important that we have these other additional roles available so that we can drive up access for the population and we can direct the population to the professional who is more suited to their presenting needs. And then your final question was about the difference between primary care dentist and the community dental services. So it is about, I suppose, specialism, if I describe it like that. So the primary care dentist are the 21 dental practitioners that I referred to in Luton that you essentially see in your communities on the high street that you can access dental services from. Community dental services are more specialist services that are for the population to access at an appropriate time and for specific cohorts of the population. Hopefully that answers some of your questions. Thank you.
Just want to still I'm not understanding. So does that mean the primary care dentists sometimes they refer to the specialists? They are the community dental services?
Yes, so they can refer to some of those other specialist dental providers that we've summarised in the paper, where we broke down for you how we use the funding that we get for delegated dental commissioning.
Thank you. Councillor Begum.
Thank you, Chair. Thank you, Amanda, for the report. I do have a lot of questions. However, I have written 7 on here that I will email for you to respond because I thought you might be here to give them to you, and I'll give one to Chair. The other question that I would like is one I had, but you answered. It would have been good to see some of the comments from the residents because what you were saying in the report doesn't match to what we get told by the residents. And if you don't mind, I would like to say some of these from my councillor phone, if you don't mind. So no phone call, can only use online system. So this is from an elderly person when I visited the Wellbeing Club. When they said they can't speak English and can't access online, receptionist was rude and said they can't help, they need to get someone else to help them. Now that's not easy access to GP service. I have 4 surgery to name, but I won't name. I'm not sure if I'm allowed to do that. Yeah, there's one, and then another one said, it feels like the receptionist run the surgery, not the practice manager or GPs. Once they're able to go get an appointment, the GPs are very nice. It's the receptionist that is running and ruining everything. Okay, so those are from the residents. My other comment was, it seems like that is for the new generation like myself, it's not accessible for the most vulnerable, or especially people who can't use the online system or can't access. Many of the ones we've been told are, they get sent a link. When I have to book an appointment, we get sent a link. I can use it, but there are a lot of people that can't use that link. So when they call, again, the receptionists are not very helpful. Am I allowed to name the surgeries, Chair, or not?
Perhaps not. If you, if I suggest you get in touch with the BLMK via email, and yeah.
Thank you. I just wanted to confirm, but I do have surgeries that people have sent to me. Some are not in my ward, some are in my ward. One of the questions that are not on here is, it would have been good to see what has been the response of residents. What have they said about this, the new modern general practice access, what they have said. Sorry, I've got points on that one. In terms of the pharmacies, I do want to say the pharmacies are very helpful, and I have found myself the pharmacies are doing a very good job. So that's a very good one, not including the supermarket surgeries, I'm afraid. I had one more comment. But yeah, I think I've covered those ones, excluding the ones that are on this. So I'll send this electronically that you can respond to. Oh, one more, sorry. In the table on page 12, it says other. Can you explain what the other is, please? 72, other.
Hi, Amanda, did you get all of that?
Sorry, I'm a bit slow flicking between the windows. Yeah, that's really helpful. I'm very happy to receive direct from the counsellor the feedback that she's summarised by practice, because it's really important to us to receive that feedback, because essentially what we need to ensure in a modern practice access model is that we continue to facilitate equity of access, and that it sounds like there are some real examples there of where our teams are not achieving that. So the best examples we've got is where residents are being supported, so they can walk into the practice and the member of the team there has the form, be it in a written version of the form or on an iPad, and they really guide the resident through the completion of that triage form. So we've got examples of practices using that model, and if practices aren't supporting residents in the way that I've just described, we do need to understand that, so we can do some more work with those practices to ensure that equity of access. And I'm very happy to share, perhaps in a future version of the report, some of the feedback that we've been getting from residents through practices, through their patient participation groups, some of that positive feedback of the difference it's made for residents. So really happy to share that. But it's important we hear where there are examples of residents having poor experience of a new model, and they can't navigate those, be it the online system or the form filling or the experiencing barriers, and we will work directly with the practices to address those.
Thank you.
Okay, has that answered your questions, Councillor? The resident feedback and the question about the access for vulnerable patients. So was there another question?
Sorry, I think it was feedback, and the questions I'll attach it in an email, CC the committee in as well. There's a lot of questions, and I don't want to rush Amanda on answering those. Thank you.
Okay, no problem. You had actually I had a question about the pharmacies, the other category.
One more question. Yeah, what are the other ones? It's a 72 in that table. What is the other?
So that is another referral source. So Pharmacy First data comes to us from NHS England, and what we've done there is illustrated for you in the table the most significant referral sources. So I could provide a breakdown of that, what's in that 72, if helpful. I could take a look at that, and I could do that offline. But it'll be a collection of other sources that are making referrals into the Pharmacy First. Sometimes it is even that it isn't appropriately categorised. So because it's a small number, it isn't broken down. I think what we've really focused on in that table is the abundance of residents that are getting through to Pharmacy First, either through their walking into the pharmacy, which is fantastic, or through that sort of signposting or referral from their general practice team, which we really want to see more of.
Thank you.
Councillor Chowdhury.
Right. Hi, Amanda. A few questions from me as well. In terms of self-care and the NHS app, it's really good that, you know, those of us who can use the app, that is available to us, and we should encourage everyone to use the app to free up resources for those who need additional support to access services. But in terms of the app, it's very limited in terms of what you can do on the app. So, I mean, an idea of when other things like booking appointments, etc., would be made available. The other question I have is around the pharmacy pathway. We do have pharmacies who give additional hours, so extra hours pharmacies, etc. And they seem to be trusted by the local community because, I mean, if they're being referred to go to that pharmacy by 111, their GP, surgeries, they tend to become a trusted pharmacy. And then in terms of those pharmacies, in terms of their pricing model, how do they price their over-the-counter medication? Because I feel that some of these pharmacies which are located within disadvantaged communities are sort of overpricing their medication. So, you know, on average, 30% more than what Boots would charge. I think that's daylight robbery, especially at a time when we're going through cost of living crisis as well. And my last and final questions is, I mean, do we have enough dentist surgeries within Luton to meet all our residents' needs? Is there enough capacity there? Thank you.
Okay, thank you for your questions. So the NHS app, I think I agree with your comments. At the moment, for some residents, the utilisation may feel restricted. So at the moment, you can view your records, you can request appointments, and there is some other functionality that you can do. We are working with our practices to open up the booking of appointments through the NHS app in time. And I think that is something that we'll see evolve and develop over the coming weeks and months with our practices, in line with that sort of modernisation of practice access that I've described. So we've done some work. We know that there is a very limited number of practices that do enable booking of appointments via the NHS app currently. So it's very, very small numbers. And I think as the national offer of the NHS app develops, we're working with our practices, with our training facility in Luton and in BLMK to really make sure that we make the best use of the NHS app over time as that develops. With regards to your question about pharmacy and the price of over-the-counter medication, can I ask to take that question away because I can't respond fully to that? So I will take that question away and provide an answer. I'll liaise with my pharmacy colleagues to provide you an accurate response to that question. I do understand your point about pharmacists, about community pharmacies and their pricing structure for some of the over-the-counter medications, and where that's particularly important for some of our vulnerable residents. And then your final question was with regards to the number of dentists. As I said, at the moment, we've got 21 dentists in Luton. We're seeing an increase in the number of activity delivery that they are doing, and we continue to work, and we will continue to work to drive up access and to assess and consider access to dentistry in line with sort of population health requirements and public health requirements. I would say that access to dental services isn't unique. Access challenges to dental services isn't unique to Luton. It isn't unique to BLMK. It is a national issue. And as an ICB, since we've been delegated the responsibility for dental commissioning, we're trying to use all the flexibilities available to us to improve access for our population.
Thank you.
Anyone else? Okay. Councillor Mead, then Isles, then Ambia.
Thank you, Chair. I don't know whether I've got this right. I'm relying upon my memory here. But the chemist near me on Hopwell Ring closes on Saturday. It isn't open at all. I don't know whether you can sort of lean on them, or any chemist who does close on a Saturday, because for a lot of people who are working, Saturday's the only day they've really got to themselves when they can go to chemists and get things sorted, as it were. You know, you're emphasising the chemist being used more and more for first point of contact if people have health concerns, etc., etc. And secondly, just carrying on from what has just been said, a lot of my constituents aren't on the internet. They don't have smartphones. All they've got is a landline telephone, and all they want to do is just ring up the surgery and make an appointment. And that seems to be more and more difficult to happen. We did ask being given multiple choices and things and press buttons which just aren't on their phones. I'll leave that with you. Thank you.
Thank you. So if I just respond regarding opening hours, pharmacists, as part of their contract, are required, to deliver a number of hours, and that's negotiated. But certainly I'll take your comments away, and we can look at that and consider that. And I mean, I suppose I've responded to the other councillors' questions, and yours are in a similar vein about how we ensure equity of access for the entire of the residents. So some people are more able to use digital tools and so on, and we need to make sure that we don't disadvantage access for residents who aren't able to use that technology, and that is certainly really important in part of our plan. And as I responded to the other councillor, if we receive feedback of where practices aren't providing that equity of access and aren't supporting residents who aren't confident with forms, with complicated telephone systems or with digital offers, then we will address that with those practices, because modern practice access is about facilitating better access, not about limiting it to those that are able to use cloud-based telephony and those new digital offers. So we take that feedback very seriously and work with our practices on that. I mean, what I would describe is, for some practices, this is new ways of working, and I think as this develops for them, we'll see some of those improvements. But yes, as an ICB, and I've put my email address in the chat, really happy to receive feedback where there are examples of the new models not facilitating resident access in the way that it should.
Okay. Councillor Ross?
Thank you, Chair. Thanks, Amanda. I just want to find out about on page 16.21, where you say continue to review the dental needs of the population of Luton. I just want to find out, how often is this review going to take place, and how is this going to be fed back or fed into all of us as such, so that we can also pass it out to residents?
So that would be, I mean, I've set out in the paper the availability of the budget that we have and how that budget is distributed across each of the components of dental services and where we spend that money. I think working with the public health team and in sort of the timetable of the needs assessments, we would do some of that annually, and we would do some of that at the frequency that we review those public health needs assessments. But we would take a view annually, and as I've described in the paper, we are trying to think all the time about how we can use the flexibilities delegated to us to really make the best use of that dental budget for the population and the needs that we're seeing in each of our places.
Okay, can I just ask another question? So you're obviously carrying out assessments, but and obviously I understand budgets are restricted, but how many people roughly do you have that's going to be doing this? Has it been set up already?
How many people do we have in the ICB? Are you
That you're
asking
going
the
to
question?
know that's going to carry out these assessments with the dental reviews? Have you got a team set up? That's what I mean.
Yes, we've got a team. So when the ICB received the delegation for dental services, it came with a resource. So we have a dedicated dental team in the ICB that oversees the contracts, the activities that I've described in the paper, and also works with other stakeholders to do that review and to ensure that we are being flexible and within the guidance and utilising the funding where that we can. So we do have a specific specialist dental team in the ICB.
Okay, thank you.
Thank you. Councillor Ambia.
Thank you, Chair. Yes, so I have a first question. On page number 13.3, you have mentioned this. You have some funding ARRS to the PCNs across the Luton, which is sounds good. But what, from my experience, what I seen, some of these, like I mean, in Luton, the PCN network, like the GPs with a different PCN is very confusing, because they are like, we as a councillor in my ward, there was a 3 PCN network, like 3 PCNs are active. So we don't know which, if any residents ask for any sort of service, because different PCN they have a different type of activity. Some of them are very active, some of them are doing very selective activities. So I find this PCN network is an additional layer that create a confusion. So this is my first experience, because like, then also I have seen there are some GP surgeries with particular PCN, they are very active, but not all of the surgeries are doing any activities. Only few I can name, very, 1 or 2 surgery which are doing regular weekly activities with their patient participants, different well-being activities that will allow to engage with the patient. So is there anything, I think, which is a very effective to engage with the local patient? So is there anything we can make sure all the GP surgeries, they can do at least weekly some sort of patient relation, like patient participants activities, to do all these some sort of general well-being activity that will allow to get to the close, that will allow to the local residents get confidence within their surgeries and GP colleagues, so that can create a more connection to and avoid all sort of barriers. I hope you understand my question.
Yeah, I think I did. Thank you very much for your question.
Yes. Okay. Number one.
So,
yeah. I have a few. Shall I continue? I have a few more questions. Also, on the page number 15, you have mentioned about.
Councillor Ambia, should we let Amanda answer that one first?
Okay.
Thank you. So I suppose in answer to that question, I think, yes, absolutely, I accept and agree completely that primary care network offers do vary, but they should be developed based on population need, and they are developed based on population need. I suppose for residents, the important thing is that you are registered with a GP practice, and that is your first essentially point of contact. So from a general practice, primary care perspective, residents are registered with a GP practice. GP practices collaborate to deliver different services and services at scale where it makes sense to do to, and they do that as primary care networks. So primary care networks bring additional offers to the population, and yes, there is some variation in those offers. But I suppose I would say that residents primarily are registered with their practice, and they should be able to access services through that route. In Luton, as we're starting to progress the work around neighbourhood working, we're looking increasingly at the offers that should be made available through those neighbourhoods to those communities, so we can scale up some of those offers where there is variation. So I think we'll start to see some of that addressed as we continue the journey around neighbourhood working. And as PCNs continue, primary care networks continue to develop their offers. But as I've said, essentially registrations continue with general practice teams. So I don't think there is a specific answer to your question. We recognise some of the challenges that you've articulated in variation, and we are working with primary care networks and we're through that integrated neighbourhood work to address where that variation isn't warranted and thinking about how we can scale up some of those offers.
Okay, thank you. Yes, another question is page number 15, 14.14. You on the last point, last paragraph, you mentioned there are only 2 dental practices in Luton that successfully secured a bid on the new ICB proposal on the dentistry contract. So what I understand is only 2 is actually a drop in the ocean compared to the whole Luton town. And what I can see is on the mention you have mentioned is 20,000 per dentist. Is it per year salary? If you can clarify this point for me, the funding of 20,000 per dentist recruit into BLMK ICB footprint. Is it yearly salary or on page number 14? Sorry, on page number 15.14.
Okay, again, so I don't get a bit lost in the detail here. Can I suggest I take that very specific question away and give you clarity?
Yes,
I'll write more clearly a response for you. I think
yeah, that's fine. So what I mentioned is only 2 dentists which they got successfully awarded, which is very, is very few portion compared to the people who were waiting to get NHS dentist appointment. Yeah. And also in the same things about you have increased some sort of tariff from 27.50 to 31 pound, which is compared to what I understand from the dentist. The thing is still the amount for units of dental activities is not is not entertain them to accept NHS patient. That's why a private dental practice are reluctant to accept go through this NHS contract. And not only for this, when I speak to one of the dentists, he said there's a lots of paperwork and barriers involved for them, which is not value for money to waste time. Is there anything you can have some sort of improve the communication or like seamless process for dentists who would like to accept the NHS process? Because the thing is they have a 2 point. One is rate, another one is too many paperwork, too many barriers. So I think you need to not only, sometimes it's not only the fees, sometimes they find the communication is too complex. And thank you.
Okay, thank you. So as we've described in the paper, we've described sort of the journey of the unit of dental activity rates, where we started at 27.50 and then the NHS funding was increased in January 2024 and at £28, and we've increased it to £31, recognising the constraints of dental activity as you've described. With regards to your comments about I suppose bureaucracy and refining process, perhaps I'll take those comments away. No, that's helpful. Thank you.
Okay, Thank you. There's nothing. Councillor Teeth. Okay.
Thank you, Chair, and thank you, Amanda, for giving us your report. I just want to refer to you, if I may, on page 15. The budget for the BLMK is 64 million. Do you have a breakdown of what that equates to the Luton area? I know we've got 120 practices, but what's the budget from 64 million for Luton? And secondly, just going back to your last point, referring back to Councillor Ambia's comments about the UDA, obviously I see it's gone up to £31. Has that affected a drop-off in people using the service? There's obviously the cost of living crisis. That's nearly 15% increase. My maths are not very good, but so it's quite a little bit rise in the cost of that. So has that caused a drop-off in the level of service people are using it? Thank you.
Thank you. So I don't have a breakdown to hand how that total budget is broken down in Luton, but I can look with my team if we can do that, if we can bring that down to the Luton Place level. So I'll add that to my list of actions to take away from this evening. The UDA, I suppose, just to clarify, the increase that we've articulated in the paper is the units of dental activity, and that's the payment that we, as an ICB, make to the dentist to deliver those activities. So it's an uplift in terms of recognising the constraints that our dental workforce tell us they face in terms of staffing, estates and so on. So that is the rate that the ICB, the Integrated Care Board, pays to the dental contractors.
Okay, Councillor Ambia.
Thank you, Chair. Actually, I don't have a question, it's a comment. I would like to just, I realize that I'd like to address. So on the report, you have mentioned about NHS app and primary fast, which is very positive. Thank you. I would like to hear more about triage process, because what I understand, what I got feedback from the residents, that triage, they need to fill the form and to go through this to start the triage process. Is it correct? They need to fill the online form for the triage.
So the requirement in the NHS contract, in the contract for general practice, is that by the 31st of March 2025, practices have to implement what they refer to as modern practice access. For most practices, that is implementing a triage approach. So typically what had happened before, and people on the committee will be familiar with this, the residents manned the phones at 8 a.m. To try to get through to their practice, to try and get an appointment that was available during that day. And that became known as the 8 a.m. rush. What the new requirements, they're not specific in how practices will do this, because every practice has a different population, has a different demographic, and actually the it's about a practice designing a system that is appropriate for its population. But most practices are delivering this new model of the basis of that is that if you ring your practice tomorrow, that you know during that day how your need will be responded to. That's not to say you'll be given an appointment, because not everybody who contacts their practice does need an appointment. So some residents may get advice, self-care, do this, try these things, and we don't think you need an appointment at this time. So it is a clinician that triages those requests from residents. So it might be self-care, it might be signposting, or it might be an appointment, and the appointment might be on the same day, or it might be booked at a time that is appropriate to the presenting need. Not all appointments will be with a GP. There'll be a member of the practice team that I've already described that will be best suited to that patient's need. Now, A number of practices who have implemented this model are asking patients to complete a form. And we know, and I've heard tonight from your colleagues, that that presents a barrier for some residents because they may not be able to use the form digitally to complete. What should happen is that you should be able to telephone, you should be able to complete an online form, or you should be able to go to your practice and somebody should help you to complete that form. Now, the form is to collect the information that the clinician will need to make that clinical triage assessment about what is the right approach. So yes, there is a form in a number of practices, but as I've already described tonight, that form shouldn't be a barrier for residents. And if it is being, we need to understand where that is happening so we can do the work with those practices to resolve that.
Thank you. Thank you.
Okay.
And,
Sorry, Councillor Amber, we need to wrap this one up. If you've got any further questions, then if you would like to email those. Thank you. Thanks very much, Amanda, for your presentation and answering our questions.
Thank you.
Thank you. We go on to item number 8, preparation for adult social care CQC assurance. That is Jill and Carl.
It's Connor.
Connor, my apologies.
Sorry, we were at the back of the room when we told you, so. Okay, so yes, colleagues, you already know me, the Director of Adults. I'd just like to introduce you to Connor Copas, who's our Principal Social Worker. He's been with us just over a month now, so very new in post, but already making a huge impact. So today we just, obviously we came and spoke to you, I think about 12 months ago, and we're just providing an update. So Connor is just going to run through the themes of this inspection for you as they've become much clearer since we were last here. And then there's a section of the slides which we're not going to present because it's about Luton, and I guess you all know, so it's there for your reading. And then I will pick up and talk about some of the areas that we're working on in order to strengthen our approach. And then take questions. Is that okay? Yeah. Okay. Over to you, Connor.
Thanks so much, Jill. Good evening. So we'll take you through our CQC inspection process to date. We'll start with some background and context. So since April 2023, the Care Quality Commission has the remit to inspect the delivery of local authorities with respect to their adult social care duties. And we look at that framework. So within the framework, there are 4 different themes. Working with people, which is that direct support, accessing needs and providing the support. In terms of the other themes, providing support around care provision, integration and continuity, safe systems in terms of pathways and transitions, and safeguarding. And the final theme, leadership, which covers governance, management and sustainability, learning, improvement and innovation. And you can see off to the side that they're the different scores: outstanding, good, requires improvement, and inadequate. So the themes linked to the assessment process: we will get our notification of assessment. From that point, CQC will review our public data. We will submit an information return following the notification within 3 weeks. We'll have an on-site visit, usually 3 to 4 days. They will draft a report after meeting with a range of colleagues throughout Luton, our residents, partners and leaders, and then they will draft a final report. Our preparation to date, we're required to complete 50 case tracking for our residents through their journey of adult social care. We have robust comms and engagement, and that's part of our presentation this evening. We have our CQC project group who meet monthly, mandatory team meetings sharing guidance and preparing the workforce for CQC assessment, an evidence library to support our information return submission, and then our self-assessment, which Jill will move on to now, looking at our strengths, areas of focus and risks identified.
Thank you. I'm just deciding whether I'm best looking at my screen or up there with my glasses on. I think maybe I'll if you take them forward, but I'll read off my screen. It's the growing old. Nothing looks right. So theme 1 is working with people. So this is essentially really understanding how we implement our social work practice. And our strengths here are very much in our really high performing community learning disability team, which does really well in all aspects. And in our recent adult social care feedback, that the scores for people receiving that type of care were really outstanding. We have a high quality council delivered care systems. That's our internal provider care, which provides a range of services such as reablement, day opportunities, and respite care. And we have a very strong prevention and enablement pathway in Luton, which is embedded within our local communities. And a really strong quality assurance framework. So that's kind of looking at the practice of social workers, really doing regular audits, checking back with customers to get their feedback on how the process was for them, and looking for any opportunities to drive up practice and improve things as we do that. Some areas of focus, though, we also, in the earlier slides, you may have seen the triangle target operating model, which is about making sure that we can really help people at the earliest opportunity and just seeing the fewest people for long-term support. Of course, some people really do need that, but wherever we can help people to get back on their feet and to live independently, then we are making every opportunity to do that. And as I say, building on that existing really great prevention and enablement service that we've got, working with our local communities, driving our community hub model and our neighbourhood working with health services. And by doing that, one of the things that we also want to do is improve the journey for people by reducing the hands off and speeding up the processes, which will improve efficiency for our staff, but also reduce the need for people to repeat their stories. Connor, you're one ahead of me, so I'm just on there, providing services. So the theme 2, providing our services. So this is mainly looking at our external services and how we work with health colleagues. Some of the titles are a little bit ambiguous, so I'll explain what they mean. So for this one, we think we've got really strong quality team that works alongside our commissioned services, our providers out there, and consistent use of the PAMS, which is a quality assurance mechanism, so that where the providers send us information in about certain aspects of care that they're delivering, and we also go in and visit them, etc., and work alongside any providers who are struggling with their quality and need to drive up their standards. We will have fantastic integrated services with the NHS, such as our joint hospital service, and a really strong Better Care Fund, which is jointly funding services together with health to drive up that integration, and strong Section 75 arrangements that helps us with joint funding for those residents who have both health and care needs, which helps us with long-term planning and stability. And ICB is actually reviewing the Better Care Fund arrangements and Section 75 across BLMK. And I haven't quite seen the report, but just a sneak spoiler for you, as Luton is by far the more advanced in that area than other boroughs across BLMK. Which much thanks actually goes to Nikki Pillane, who isn't here today, but for always championing that work over the years since she's been with the CCG. We also have, as well as part of that, a really active Luton at Place board where we make decisions and drive up quality locally with health and our voluntary sector colleagues and social care. But we do recognise that we've got some areas for improvement in terms of really strengthening our commissioning approach to become more strategic and work with longer term relationship with our partnerships with our provider services. And I'll probably talk to you more about that in January as well when we look at the improvement and how that impacts on the budget. That will be a big part of that. We think that we could do with understanding and creating more bespoke pathways to meet the needs of our diverse community, and refreshing our carer strategy implementation plan, which we brought to you a couple of months ago, and we're now implementing that plan. But obviously, we've just started that, so it's an area of focus for us to drive up that reform and support for unpaid carers. And we're also really improving our co-production activity, so that we really want to embed that as a golden thread through absolutely everything that we do and be able to evidence it. And that is really key. So it's not just we're going to do this or we did speak to residents, but this is what our residents said. Just as Councillor Begum asked this evening of our NHS colleagues, what were the voices? And we want to bring that into all of our work. Theme 3 then is safer systems. So for this is largely looking at our safeguarding practice and other points of law where we need to protect people's safety and ensure that they're not being exploited. So we have here a really high performing multi-agency safeguarding hub, or MASH. Many local authorities have this for children's but not for adults. So we're really proud of that service. And we have effective Section 42 inquiries. We have a really rapid response to deprivation of liberty safeguard, and with no late waiting lists, unlike many other areas, and a leading authority in quarter protection dolls cases. We have a really strong pathway for our young people with learning disability or autism, and a strong transition from hospital care at home to high performing reablement services. The areas that we want to focus in, though, is our transitions for other young people, particularly those with social, emotional and mental health needs. And that is covered as part of our, and that's what that acronym is, the All Age Mental Health Strategy. That is a partnership arrangement across public health, health services and children's services and adult services. And we participate in just started actually a review by partners in health and care who support the LGA in supporting councils in improvements, to review our safeguarding adult board to look at opportunities to strengthen how that board works as a partnership together. And doing that, obviously, we've got Alan on the call today, but we're taking the opportunity as children's are reviewing their approaches, and Alan will be retiring and stepping down as chair of the Adult Safeguarding Board. So we are taking that opportunity. Finally, theme 4 for leadership. Again, strength our partnership and at Place Board. We are a front runner across Bedfordshire for falls prevention. We have a really strong joint strategic commissioning board to agree and monitor spend together with the ICB. And we have a strong co-produced workforce strategy for social care, which includes how we grow our own social workers and occupational therapists, to really strengthen the workforce within adult social care, and to ensure that our social care workforce represents the local community. Really important that, and that we've got fantastic representation from the local community. Our areas of focus, like many other authorities, is that recruitment and retention challenges across adult social care. So that's not just within social work, but also within our provider market. And we know that the health struggles with that too. We want to strengthen our identification and support for victims of modern day slavery working in the care sector, and we've got a number of schemes underway for that. And we want to support the development of leadership in adult social care. So we've got really strong progression planning. So after we're getting to management level, what next? How do we help people go on into those senior leadership roles, and how we're going to work through that? And then we've also introduced TriX, which is a brand name, but is a platform for our policies and procedures. So, and we're working on that now. So there's a single place for that to go, for all the policies and procedures to go to and to be stored, so that practitioners can access that easily, and our provider services. and we're just going to do more work to kind of make them more bespoke and Lutonise them where required. And then the final slide is really just to highlight what we think of the top 3 risks, because one of the things that CQC will really be looking for is for us to be, you know, a bit honest about where we see the challenges and what we're doing about them. So our waiting times are longer than we would like, and we've done a lot of work in the last 12 months to really reduce our social care assessment waiting list. And so the numbers for that have significantly dropped from around 500 to just under 100 people on that list, not the same people, obviously, 12 months later, but who are waiting longer than 28 days to be seen. But our waits for occupational therapy have remained stubbornly high and around about the same rate. So we are now developing an action plan specifically on occupational therapy to do more around that in the next 6 to 12 months. We think we could be doing more as a system to develop new ways of providing therapy to maximise people's independence and make the best of scarce resources. And so we're working and speaking to our ICB colleagues and health colleagues in relation to that. We know that in 2023-24, about 46% of complaints were due to a delay in providing a service. But as I say, we've done a lot of work on that, and we think that we expect that complaint number to fall in this year. We've already seen a reduction in stage 2 complaints and in people going to the LGO. So our demand for adult social care is another of our risks. So we have an increase in demand as a result of an ageing population, lots of complexity, obviously, in Luton, and high numbers of young people with learning disability transferring to adult services every year. So in the last 3 years, that's been around 60. Next year, it will be 76 people, and the following year, 112. So it's a real significant risk, and I'm sure in other venues you will have heard of children's growth in the SEND population and special schools, and it's all transferring up to adults, obviously, as children mature into young adults. We have had new people contacting the accountant, at least 1,500 increase year on year for the last 3 years. So we're now at levels higher than pre-COVID levels. So we're really trying to manage that demand. And I say a lot of our prevention and early intervention work is doing that. So not all of those people transfer into care. And actually the number of people that we support with care packages has remained about the same. Some small increases, but nothing like 1,500 a year. And our vision, our 2040 vision, to reduce poverty and poor health and inequality in Luton, will continue to sustain our ability to support people to manage on their own and to be independent and to reduce those contacts. But obviously that is a long-term plan. And finally, as I mentioned earlier, our other risk is our commissioned care provider market. So Luton has seen a number of providers close or withdraw from our contracts in the last couple of years. So we know that it is a fragile market and we need to do more to support them. And as I say, thinking about those long-term partnership arrangements is key to that. So yeah, that's our presentation, and I'm happy to take any questions.
Thank you both. Councillor Nasser, then Councillor Chowdhury.
Thank you, Chair, and thank you both. It's actually lots of information to digest. Actually, my question is about, because this is for my constituents. I mean, the residents do come to us regarding the care, adults care at home. So are we every day we come across people who doesn't speak English or speak a little bit English, which you in your demographic is 20.5%. So when we see that they sometimes they request, if it's a female, they ask for a female carer, and also they do request for if they can speak the same language, but which is not possible always. So it's so how it will be possible to monitor that the care provider service, they are handling these demands and, hiring staff appropriately?
Yes, so you're making really valid points, and we do whatever we can when new people, when we are looking at people's needs and trying to match those needs. So we would always look at somebody who needed a specific language spoken, or a specific gender. But you're quite right, we can't always comply with that. But we make sure that that is noted on the care record, and we can go back and review that and try to address that. You be aware there's over 100 languages spoken in Luton, so always being able to match the right carer to the right person and language isn't always possible, particularly at the beginning, because if you've got a starter package tomorrow or next week, the most important thing is that people get their care delivered. But we will continue to work on that and try to swap that out. And I'd love to hear from anyone who's having difficulties there, and we can look and see what we could do. Sometimes it's challenging, and we have to go to another provider to do that, and that can be a bit of upheaval. So we would always work with the resident and their family and say, is this what you want? It would be disruptive, but if that's really what you want, we have now found a provider who could provide that. But it is challenging. And there's no easy way forward, really, because there are just so many languages, but we do our very best to ensure that. And we do have a lot of people from the local workforce working in our services, and our new contracts actually encourage more local providers to come forward. So we're hoping to get more workforce from our local community, which will help and support with those specific needs.
Yeah, thank you. I mean, I think this will be challenging, always. I mean, there will always be a loophole. And if we can, the local services, if we can, help them as well to, take it forward for the local residents to, as a staff and, hiring them, I think that's the way it will be a little bit improvement.
Absolutely. And all of the providers that we work with have registered officers and are local in Luton.
Thank you. Councillor Chowdhury?
I haven't got much today, sorry. Just wanted to ask, I know we're all preparing for the CQC inspection. How confident are we that will pass with a good or, hasten to say, outstanding perhaps? And have we done a self-assessment in terms of where we are, how prepared we think we are for the CQC inspection?
Yes, so we're doing a lot of preparation work. So we are really writing reports like this. This was actually a report that we not only shared with you, but also our local stakeholders, so our health and care partners, our voluntary sector partners, just around a month ago, in fact, in this room. And we were asking them, is this what you think? And, is this what is our self-assessment, because this is part of our self-assessment, is it accurate? Are there more things that we need to learn and take forward from that? And we will continue to do that, because we need to listen to the voices of our stakeholders. And similarly, we are having sessions with our residents to hear what they're saying, and working with our staff to hear what they think, and weighing up all of these things. We do have an improvement programme as well to channel our efforts into these areas that we're saying we're going to focus on. It's easy to get carried away. You could do everything all the time, but we have to really focus and say these are the things that we think are the priorities. So we have a really well mapped out plan to deliver that and to take that forward. What we don't know is what day CQC will arrive. So will they come, will I get a call this week, or will it be in 9 months' time? Now, depending on when that comes, we'll probably factor in what the outcome would be, because we might be further along in that journey, or we may be at a time of particular disruption. Perhaps somebody's left and they're worried about that. It's a little bit hard to say what score we would get. There has been still only less than a third of councils inspected, and the way that they're inspecting and the kind of feedback they're getting is changing. So it's quite a fluid position. So I wouldn't want to stake what exactly score we would get. But what I would say is that I feel a lot more confident than I did 12 months ago, and that confidence is building. So I think we're on the right track, and we're doing everything that we can to get the best possible score.
Thank you. Can I just ask one more follow-up question? I guess you're doing a lot of engagement with our users as well, users of our services. I mean, if there's any way we as members can help you sort of get feedback or engage with users, please let us know, users. I mean, we're here to support you.
Oh, lovely. Thank you. Thank you. That's really kind. And it's actually Carers Day. I think, is it Thursday this week? I think it is. I think it's on this Thursday, and there'll be a stall in the shopping mall, and Councillor Bassett, who's obviously our lead member, he will be there to meet carers and hear directly from them. And it's those kind of events that we really want to promote and make sure that people know their support for carers, but also there's bound to be some carers who've come across our services and have feedback for us, positive or negative. We need to hear that so that we can reflect and think about where we need to go. So do join in with any of those. You'd be more than welcome.
Thank you. That's a very useful suggestion. So yeah, thank you. Councillor Ambia.
Thank you, Chair. On the page, I'm referring the diagram which you mentioned on the page number 31. If you can explain those figures like POP and HH, what does it mean? If you can explain all the, like on page number 31, there are diagrams on the area wise, north, east, south. If you can explain all these figures that, like, I mean, all the levels POP and HH, what does it mean?
I think it's this slide.
I think is.
Yeah, can we just, is it this, just to check, it's this slide.
POP is population and HH is households.
Which was the specific question you had? It's this slide, isn't it? The next one, okay. So this is about, so this is looking at, yeah, okay, yeah, so I've got this. So this is looking at, these are the 5 neighbourhoods. So the 5 colours you've got there are the neighbourhoods that we have agreed as a health and care system, that how we will group the wards into these neighbourhoods. So at the top, the population there with the asterisk, that's the population of, so in North Luton, that's in that yellow, in those 4 wards that make up the North Luton neighbourhood. So that's the population there. I'm trying to think what the H and H is. Households, there we are, thank you. This is a public health slide and I suddenly got stuck with the acronym, but yes, so that's the number of households and the number of populations. And then you've got the average persons per household is the next one, so 2.7 in that area. And then the adult social care demand in 22-23 was 92 people per 10,000 population, which you'll see is roughly equal in all neighbourhoods except for West Central, which is significantly less adult social care demand in that area, and is something that we really want to unpick. And we're moving our teams into 2 localities which will cover 3 and 2 neighbourhoods, so that we get much closer into the communities and to really understand why the demand is lower in West Central, because it is an area of deprivation, so we would expect it to be higher. So that's something that we want to explore.
Okay. Councillor Teeth.
Can I just come in and give you a little bit of insight on that? I think it's a lot of the families are looking after the adults by themselves. There's a lot of large families in that. And I think that's what.
Yeah, that's probably
they're taking up the service.
Yeah, there's a lot of extended families there and they're caring for, but what we would really like to know, even if they're not coming to demands, we'd like to recognise them as carers and understand their needs. So as that becomes more challenging, then we can offer some small levels of support, because sometimes people wait until there's a crisis, and we'd be able to help them a lot more and avoid crises if we could get into there.
Yeah, Councillor Chowdhury.
Just to add on to what my colleague was saying, I think it's primarily access to services, not knowing what the offer is or what's available there. I mean, through my day job, we do a lot of work within that ward, and it is because most of the people have language barriers, IT barriers, etc. Although they're looking after families, but then there's carers. Do they know what the carer support offer is? It's about respite care as well. Are they taking? Do they know what the offer is at the moment? So it's, I think, lack of access, lack of awareness of the services as well. Maybe that's something we could possibly sort of look into as a ward councillor as well.
Yes, absolutely. Be great.
Okay, thank you. I've got a couple of questions. Find my notes. So I'm getting the impression that I don't think I've asked this question before, that this CQC assurance process, it would have been a useful exercise anyway, the preparation that you're doing, notwithstanding the fact that we're going to have this assurance exercise. Sorry.
Yeah, no, absolutely. It's really helpful process. I mean, nobody really likes, to think that you're going to get marked and the worry of all that. But on the other hand, what they're looking for is, have we implemented the Care Act? Are we delivering our statutory duties well? And that can only be a good thing, really, that's focusing our attention, especially in times that are particularly challenging financially and for our population with, still lots of health needs, etc. It's good that we're focusing really on driving up that quality and really thinking about, are we delivering the Care Act in the way that is intended?
What's the latest date that we could be paid a visit?
They were wanting to start everything off by the end of next year, aren't they? Yes. So they're by the end of this year, they'll be like about a year through, if you include the pilots. So they started the other inspections following the pilots from about April, and they said they do hope to announce that they will be coming to visit every local authority by the end of next year. So we're about halfway through the timeline. And they've just announced, just to let you know, in the Eastern region, they've already done Hertfordshire, Suffolk, Essex is underway, and they've just in the last couple of weeks announced Peterborough and Cambridgeshire. So there's not many left in the East.
So it could be some months away. Is there any danger of getting preparation fatigue, of going through this process so much that I don't know, you lose focus?
No, I don't think so. I think because we're wrapping it up in our daily business. Mm-hmm. So we pull these slides together for stakeholders and for yourselves, but this is our core business, day in, day out, delivering this. We're not constantly having everyone running around going, oh, CQC might come. I think you'd be right thinking that. We're just moving forward. This is what good practice looks like. How do we improve? Let's look at some innovation, celebrating what we're doing really well. The team's morale is very, very good. I think, mm-hmm. Connor, isn't it? You've not been with us long, but Connor feels that he's walked into, a really strong team. Do you want to come in?
Yeah, absolutely. It's been great. I think colleagues are so proud of the work that they do. And I think a lot of people not only work in Luton, but live in Luton. I think that takes on a different ownership and a pride for the community. And again, we're not doing this for CQC. We're doing this for best practice and for the residents of Luton. So that's our message.
That's very good to hear. It's very encouraging to hear. couple more. Theme 3, safe systems. The area of focus is participating in a Partners in Health and Care review of our Safeguarding Adult Board. What would that involve?
The review of the Safeguarding Adult Board. Yeah. Yes. So, as I mentioned, so Partners in Health and Care are an organisation commissioned by the LGA to work alongside councils on a range of issues, and they say this is the support pack this year, and there's a range of different things that they would do. And one of the things that they've said is that we would like to support people to kind of review the adult safeguarding adults board to make sure that it's functioning well, that it's a statutory duty of mine as Director of Adult Social Care to convene that board, but it is actually a partnership responsibility. So the other statutory partners to that board are the police and and health. And so part of the review is looking at, well, are all the partners really invested in it? Are we all working together well? And do we all really understand what we're doing in relation to preventing safeguarding, to managing safeguarding, and really driving through those messages? It's a perfect segue, isn't it, into the next item. But as I said, we always had an element of a joint business unit and a very collaborative approach with children's, which we want to keep, because transitional safeguarding is something that's really important. However, in children's legislation, there's been a new piece of legislation or guidance which says that they need to move away and become a slightly different board that is chaired by the Director of Social Services and have an independent scrutineer as opposed to an independent chair. So it's slightly different, and it's also a lot of other components that mean additional work. And so we knew it would be difficult for the business unit to be able to work across both of those agendas. There was just too much change for the size of the business unit that we have at the moment. And at the same time, or round about the same time of that, Alan, who's on the call, so I feel like I'm talking about him when he's here, but has decided that he's a time he wants to retire, and so he wants to step down. So it's just a perfect opportunity, really, for us to take stock, look at where our board could move in the future, make sure that our partners are on board and that we've got that joint approach, and see if there's anything that we could do different by just having an independent eye come and look at it and look at how the business units would support and what kind of things we might want to look for in a future chair. So that's the purpose of the review. It's a very short review. I think it's about 10 days work, all done in a month. So it's lots of interviews with the statutory partners and other partners, getting their feedback and then coming with some proposals. So that's the purpose. That will help us reset as we move to recruit a new chair and refresh our business unit.
Okay, so there's no concerns about the multi-agency working at the moment. I mean, I noticed that one of the strengths is the high-performing multi-agency safeguarding hub.
Yeah, so there's no specific concerns. It's just really about always looking for how do we make it even better? How do we make it, what can we do more to really drive that practice? Because nothing like that should stand still. You should always be trying to get the next rung up the ladder.
Okay, last one from me is in the same section, safe systems. One of the strengths is a strong transition from hospital to care at home. Is that something that's improved recently? Because wasn't that an area of concern in the recent past, or am I mistaken?
It's not. No, it's not. It's not. No, we think that we've got a good process, as we've got a joint team working in the hospital together, and so that runs fairly smoothly. I would say it is concerning in that we've got great pressures in that system. So we have a lot of people coming through the hospital system, which means we have a lot of pressure. It's very difficult for the hospital to keep its flow going and to manage the amount of people that are attending and being admitted to hospital. On the whole, we can discharge people smoothly and quickly. We have some areas of concern in relation to our capacity in residential and nursing care, which is one of the things that we talked about at the Health and Wellbeing Board. So that sometimes can cause some delays. We're talking delays of days, not weeks, but nevertheless would be something that we'd want to improve. But there's no major concerns there. I think as a whole, we're working well together with our health system.
Okay, thank you. I have nothing else. Oh, Councillor Nasser, yes, go ahead.
Yeah, I just what Connor said. I mean, actually, that actually makes feel, very powerful. So, I mean, we shouldn't be worried. This is just something new, and there are always places for improvement. So we shouldn't be worrying. We just have to do our job the way you are doing a great job. Thanks.
Thank you. I think that Councillor Nasser's just done my summary for me. So, yeah, thank you very much. Yeah, Councillor Ambier, please. Yeah, if you can make it
Thank you, Chair.
quick.
Yes, on the number 5, you said it's like formal inspection began on April 2024, but the 5 pilot scheme inspection. So I understand that the CQC, they have changed their inspection criteria or methodology. Do you have what is the significant change from previous process and their new process? Have you get any sort of experience from other authority? What is the difference on the new process, inspection process?
Yeah, we've got lots of learning from other authorities. I mean, essentially, I think they just tightened up their processes a little bit, really. So I think the first time when they did the pilots, they asked for such reams of information and local authorities didn't know what to send. So we're sending hundreds and hundreds of documents for them to review. So they now have got a very clear list of 39 documents. This is what we want to see, and nothing more. So it's they've tightened up those processes. I think the other area was potentially who they spoke to. I think they weren't really thinking about speaking to frontline staff so much at the beginning. They're also very clear about how many residents they're going to speak to, what other stakeholders and councillors they want to speak to, the chair of health and wellbeing. So they're just more tightened up. In those 5 pilots, they were just testing things out. And I think, like anyone, when you do something new, maybe a little bit naive, and then they've gone, oh, we need to be a little bit firmer in what we're going to do, otherwise it's going to get a bit overwhelming. But we've got loads of learning. So in our eastern region, we're always talking to colleagues who've been through the process. They regularly come and report to us and worked alongside us, particularly Hertfordshire, actually, who almost got an outstanding. So they did fantastically well. And they've been working with us, looking at our performance data, colleagues in the same role, working together, etc. So lots of learning.
So do you think on the new process, they will spend more time to engage to the service user and the provider, or it is a less interaction on the interview process and etc.?
It's probably a bit less, but it's just different, I think. So I think previously, they were on site for about 5 days. They're probably only going to be on site for 3 days now. But they have some open sessions, so they potentially could see more people, depending on who turns up in these drop-ins that they have. We know exactly they will pick, I think it's about 10 residents that they'll want to speak to out of 50 cases that we share with them. So they're very clear on that. I think it would be nicer for them to come to let some more focus groups and more residents can be involved, but they've chosen that methodology and that's what they're sticking with at the moment. So it'll be 5 residents or families, and it will be 10 residents or families. It will be a range of stakeholders, which we've got the list for and has been shared with the stakeholders, including Councillor Underwood as the chair of Scrutiny, and it will be certain people within my team, and then a range of my frontline staff. That's what they'll really be honing in on. What do the frontline social workers say? They don't want to hear all the management spiel. They're like, we want to hear it from the horse's mouth. What are you proud of? What are you doing about this? What happens at this point?
Thank you. Thank you both for presenting this evening. Yep, I think yes, it is reassuring, the message that you're bringing us about the confidence that you have in the upcoming inspection. Okay, if we move on quickly on to item number 9, the Luton Safeguarding Adults Board Annual Report 23-24. Alan?
Good afternoon, Chair. Evening, even. Thank you for the invite. Yeah, I've got Bev with me as well. And I should say thanks to Bev, because Bev does all the hard work in pulling the report together. It is a very lengthy report, as you will see, so I'm not going to intend to go through it all page by page, but just hit up on a couple of issues that I thought would be worth mentioning, and then leave some time for questioning. And I'm very conscious we've got Jill and Sam and Connor in the room as well, who can assist us with any sort of operational type questions you may want to ask. So without further ado, just to talk a little bit about safeguarding and what it is, for those that don't know. And the reason I mention this is because somebody actually asked me, who works in a local authority, what actually safeguarding meant, and it's basically the ability to protect an adult's right to live in safety, free from abuse and neglect. And that's the sort of phraseology we tend to use, keeping adults safe from abuse and neglect. And it's all about actually getting people and organisations to work together to prevent and stop both the risks and the experiences of abuse and neglect, while at the same time making sure that the adult's well-being is promoted. And it includes, where appropriate, having regard to their views, their feelings, their wishes and beliefs in deciding on any actions we might want to take to support them. And underpinning all of that under the Care Act and the way the Safeguarding Board works are 6 key principles. So the first one is around empowerment, and that's about people being supported and encouraged to make their own and informed own decisions and informed consent when we deal with them. Prevention, clearly it's obviously much better to take action before harm actually occurs. Proportionality, we want to use the least most intrusive response to the risk that's being presented. Protection, obviously we want to support and protect those who require the greatest need. And partnership, so the board is all about getting agencies together, and it's all about through local solutions, local services, working with their communities. And it's acknowledging that communities have a part to play in preventing, detecting and reporting neglect and abuse. So and accountability, of course, and of course there has to be accountability in every system, and the Safeguarding Adult Board is no exception to that. And finally, underpinning all of those principles is the ability to make safeguarding personal. So it's really looking at the individual's needs and bespoke and tailor making the support that fits that each individual. Again, going back to what I said about depending on their wishes, their feelings, etc., etc. So in relation to the Safeguarding Adult Board, authority area must set up the main objective of the board is itself that local safeguarding arrangements and partners act to help and protect adults in its area who have care and support needs. So that's basically the core duty of the Safeguarding Adult Board. And there are 3 core duties that the board has to do. One is to publish a strategic business plan. 2 is to conduct safeguarding adult reviews, and I'll talk a bit about them in a minute. And the 3rd one is to publish the annual report, and it's the annual report that you're seeing here today. So what you have in front of you today is the annual report for 23-24. And I think, as I said in my introduction of the report, I mean, safeguarding is challenging and complex. And Luton, like many other places across the UK, have seen health and social care systems having to cope with considerable increases in demand. And as I overheard Jill mentioning earlier, we're against a backdrop now of significant financial pressures as well, very significant financial pressures. So it's a real challenging area of work, and the complexity of safeguarding doesn't get any easier for practitioners. As the multiple needs of some individuals really makes the frontline social worker and practitioners working with those individuals have a very, very complex role in sort of trying to meet their needs and protect them effectively. I suppose one area that I wanted to mention, and again, Jill did mention this when she was going through her slides, was around transitional safeguarding. And as Jill mentioned, I also am the chair of the children's partnership as well as the adult board, and I see a lot of adolescents, 16, 15, 16, 17-year-olds who are being exploited, criminally exploited, sexually exploited. And there's a very strong wraparound service within children's social care for those children who need effective safeguarding. But of course, once those children reach 18, services don't need to be ceased, because they still have definite need for support. So it's about how we manage that, and I don't think we do that as effectively as we could. There are those children and adolescents who transition from children's services into adult services, be that mental health needs or exploitation, who actually are not getting perhaps the services that they need, and we're not intervening early enough, or the coordination between children's social care and adult social care is not perhaps as effective as it could be. And this is not just in Luton. I mean, this is most places, and we're talking about this now across the country as a real problem area. So, and there's been a number of safeguarding adult reviews that have been undertaken, not here, but in certainly in Bedford Borough, where an 18-year-old has sadly died, and actually a second one has just been commissioned where an 18-year-old has sadly died. And the way agencies work together, there's a lot of learning coming out of those. So I think as a partnership, we need to make sure we take on board that learning and improve our services where we can. So talking about SARS, Safeguarding Adult Reviews, you're probably all aware we have to undertake a Safeguarding Adult Review if an adult with care and support needs in our area has died or has been seriously harmed as a result of abuse or neglect, and that there are concerns around the way agencies work together to protect and support that individual. And there are details of the Safeguarding Adult Reviews that we taken on page sort of 57 onwards. And these SARs are undertaken, basically, they're not there to highlight any blame to organisations or individuals, but it is about identifying improvements in the safeguarding system in order to promote effective learning and improvement action to prevent future deaths or serious harm occurring again. And there are a number of themes on, I think, page 49, which Bev has sort of highlighted from the SARs that we have undertaken, which talks about, what themes we've been finding over recent years that kept coming up. We talk about professional curiosity. We talk about, let me find the page here and I can sort of run through some of those. Lack of professional curiosity and questioning, lack of multi-agency working, no clear safeguarding plans, and lack of trained staff in mental capacity assessments. These were similar themes coming up over the past few years. And I think what Bev has articulated there is that how that learning has since been embedded into practice, and the changes that we've been able to make as a result of some of those safeguarding adult reviews. So I think in last year's report, when I came to you, I think there were concerns that we were seeing similar themes from safeguarding adult reviews that weren't perhaps being as embedded as we would have, as well as we would have liked. But actually, seen a real change in that, and some of the audit work that again is mentioned in the report highlights where we can evidence that improvement is happening across the safeguarding system. So yeah, the other thing I briefly wanted to talk about, so that talks about the safeguarding adult reviews, and we do have a very good process in Luton where we manage those referrals and we undertake those reviews. The other thing I just wanted to briefly mention is about right care, right person. We've seen a number of reports into the Safeguarding Adult Board about the introduction of this new, it's basically a police operational model, which is being rolled out not only in Luton but across the UK, which makes sure that it's basically to ensure that people with mental health needs, be they absence from a hospital or whatever, get the right response and not necessarily relying on the police as that first port of call. The police were sort of very analytical in their approach, thinking the amount of time that they spend attending what they call mental health cases, which is not really their skill or specialism if there aren't any crimes being committed, was taking up an undue amount of time. So the partnership has worked very closely together across Bedfordshire and particularly in Luton to ensure that right care, right person is being rolled out. And like I said, in the board, we've had a number of presentations from the personnel in the police and the health services who have pulled all this together. So it's quite assuring now that I think we're at a process where it is being rolled out, and that people in crisis are getting the right care. And it's it's always about ensuring that we get the right care being delivered by the right person. And we'll continue to monitor that, because I obviously did have some concerns that if the police weren't going as a first port of call, we could end up with some serious harm being caused to some individuals. But that hasn't played out, which I'm pleased to say, and the police have put a lot of work into making sure that works. The report also outlines on page 73 onwards the sort of scrutiny and audit work we undertake to assure our effectiveness. So that the audit work that's undergone on a multi-agency process, where they will sit and analyse a number of different cases, and that you'll see in the report some of the findings from those audits and the implementation of learning from those audits as well. So it's been a really busy year for the partnership, particularly with the learning from SARS and the number of SARS that undertake. I mean, you can't underestimate the amount of time that needs to be taken in formulating and undertaking a safeguarding adult review. The other thing that's kind of coming into play now, particularly after a government request, was for us to particularly look at rough sleeping and homelessness within the board setting, and that now is happening. I think, I was very assured when we had the homelessness unit come and talk to the board about the work that they do in Luton. It is an issue in Luton, and there's a lot of work goes on to identify and recognise and support those individuals who are rough sleeping and homeless across Luton. But now as a board, we've got to add that into our sort of priorities and oversee some governance around those individuals. So basically, in conclusion, I obviously can go on, Chair, because there's a lot in that report, but I'll bring it to a close now, just to say that, I think there is a very good partnership across Luton. I certainly would echo Jill's comments around the effectiveness of the partnership, that there is good collaborative work. There is a willingness to improve practice across the whole sector, which is that wider partnership, because there are a number of people who are present on the Safeguarding Adult Board. There's good leadership from each of the agencies to drive forward those changes that we all seem to want, and we're always looking at how we can improve our outcomes. So also just attached, you've got various appendices attached to the report as well. You've got the Safeguarding Adult details of data that's on the Appendix A, Appendix B. You've got the partners reports, and you might want to spend some time looking at Appendix B. You've got some real detailed outcomes from individual partner agencies that sit on the board about the work that they've been doing to effectively safeguard and promote the welfare of some of our most vulnerable and elderly people across Luton. And the police have given some really good examples in there as well, and there's some particular examples in there about how they've managed individuals who have been trafficked into this country and where modern day slavery has been an issue. So, these things go on in Luton, and I'm pleased as a partnership we're always looking to see how we can combat those particular issues. So without further ado, Chair, I think that's probably a good enough sort of introduction. There's a couple of bits there I've just mentioned. Obviously, there's a lot in the report, but obviously there's myself, Bev, Jill, Connor and Sam that are perhaps here that we can answer, hopefully, between us, any questions that you might have.
Yep, thank you, Alan. Yep, as you say, it is a very long report and detailed report with all the appendices and all the links that you can dive down into. So I'll take your point about if people want to read through those, and if anyone has any questions that aren't immediately obvious tonight or we can't be answered tonight, is that okay if they address those to? Yeah, okay, that's great.
Yeah, absolutely.
Okay, thank you. Yeah, and just to thank all the people involved in producing the report. Okay, Councillor Chowdhury.
I'd like to make an observation, really. Just wanted to know, in terms of safeguarding, we all have a duty, even as members, we have a duty towards safeguarding. how is that sort of message given out to the community, to different stakeholders, so that we're all aware of safeguarding? The other thing, another observation I'd like to make, it would have been really good to have some data, make it a bit more pretty for us to better absorb the report as well. I was specifically looking at the offer around domestic violence. It would be really good to know, how many people, how many males and females accessed, our offer, the partners' offers, and are they accessing to identify, are people accessing the right sort of support, and is there enough prevention work going on? Because I, as a sort of member, I'm quite confused if someone comes to me with a domestic violence issue, where in terms of the early intervention work, where do I send them? Because it's very confusing for me as a member, let alone a person going through DV themselves.
Shall I start, Chair, and just give my certainly domestic abuse. If domestic abuse is certainly a blight on society today, and certainly it impacts everybody involved. And I would sort of advocate, if there was any hint of any domestic abuse and criminal activity being involved, then the first port of contact should really be the police. If there's no immediate sort of criminal activity, but there's an ongoing domestic abuse and there's potential for, need for support for that individual, then there's a referral that could be made to the front door, who will have access to the various domestic abuse services that could support that victim. But certainly, and as you say right at the beginning, safeguarding is everybody's responsibility, and it's very key for us wherever we are, wherever we go, and however we communicate our message, that it's quite clear that we always bang on that drum, that safeguarding is everybody's responsibility. It's not just the role of adult social care in Luton or children's social care where children are concerned. It is everybody's responsibility, and that's certainly one of the reasons we have a multi-agency safeguarding adult board. It certainly spreads the message around all agencies that they are joint and equally responsible for safeguarding of all our adults with care and support needs across Luton. So that message continually is mentioned, but I think probably there is more we could do in the community. And I think, like you say, you're all responsible for safeguarding as much as anybody else. And I think that's a message that needs to go out in whenever we get out into the community, whatever role we have. I don't know if any of my colleagues, whether Sam or Jill, would want to come in, particularly about the domestic abuse, input.
So, well, as you said, there's a range of different agencies, but every act of domestic abuse, even if it's non-violent, is also criminal under the law now. So you can always phone the police or encourage people to do that. And we have dedicated agencies that can help specifically with domestic violence, which I don't have the list off the top of my head, I'm sorry, but we can get those to you, no problem. I just want to talk about kind of making safeguarding everyone's business, because I think that's such an important thing. And it is actually Safeguarding Week this week. So how perfect a time to talk about it. And so Connor has been working alongside Sam's team to raise some awareness this week. And I don't know if you want to just talk about that just briefly, Connor.
Absolutely. Yeah, well, I know Mark's on the call as well, so we met up with Mark last week to record a video for the wider council to raise awareness around safeguarding, but equally to promote the word and engage with residents to make sure that they're aware how to raise a safeguarding, how to protect themselves and their community. And really, it's keeping the conversation going, that people do feel safe in their community, they're able to access the correct services. And again, bringing it back, another reason why I'm so proud to join Luton Council is our CARES values. And one of those values are empowerment, and that's one of our principles in safeguarding. So that's something that we really want to empower our communities with, and our workforce with the knowledge, making use of the agencies. And since it's Awareness Week, we're liaising with all the different departments to ensure that they know how to respond appropriately, proportionately, and that we're maximising not only the communication but the resources we have. And today we have a document that we looked at, which I think Sam's going to speak about.
Yeah, so resources are ever being added as well to kind of support awareness. I think earlier we touched on the 7-minute briefings. So they've been developed this year. They're a relatively new resource, and certainly they're being rolled out. And there's ongoing work to make sure that they've got a further reach, because what they do is kind of give you a short briefing on lots of different elements of safeguarding. And we're also looking at some new initiatives of how we might have practitioners actually deliver some of that for our wider local authority workforce, but then also for our partnership and local community. But yes, certainly we've looked at a document. So a big piece of work's been going on across the partnership, which is a framework for shared understanding. And so that will be rolled out fairly shortly. And I think that will be very informative for everybody. And it's really to help. It's just kind of an aid memoir to some degree, but it's really well broken out, and it's talking to everyone about their responsibilities for safeguarding, how they can help manage safeguarding, obviously where to access support, gives you kind of a green, amber, red indications of maybe how a concern might be viewed. So I think that will be really, really helpful, and we will be obviously planning considerable comms around that and how we get that out to people as well. So just from an adult social care perspective, but also as part of the Safeguarding Adult Partnership.
And I'd just finally like to say, if members would like specific sessions with us about safeguarding, then we'd be more than happy to run those and to talk to you about the kind of cases that you must encounter and how to help you work with those. More than happy to.
Yeah, that would be a great idea. Yeah.
Can I just come back? No, thank you for that offer. What I was thinking in terms of domestic abuse, I like the word empowerment. I mean, initially, especially the ward I represent, a majority of the community, there are sort of cultural barriers, language barriers. So in terms of being aware of what services are available to them, or, I mean, someone going through abuse, it doesn't have to be physical abuse, could be financial, could be mental, coercion. It's how do we empower them to actually seek the help, because they have to be in a place sort of to be able to make that decision, take that first step to get that help. Initially, a lot of people don't like to sort of say that they are suffering. You can see the signs, but they don't want to come out and say that they're actually suffering from any type of abuse, because they're just scared of the symptoms. I mean, even sort of domestic abuse in relationships. I mean, people have to be able to make that decision and feel empowered to make that decision, to take that first step. So it's how do we get the messaging out there to make it easier for people to know how to access those services that are available to them?
So I think you make excellent points, Councillor Chowdhury. And what I suggest is, rather than me try and answer that here, why don't we hook up with our domestic abuse services and colleagues in public health and have a little session exploring some of these things and things that we could do differently, because I think that would be really worthwhile, and really get to the heart of the community, because that's really what we need as well, to really be able to access the community. And if you and colleagues have got ways in there that we might not have, we need to capitalise on that and have you alongside us championing this and working together. So let's arrange that.
Yeah. Sorry.
It's not working.
Yeah. Sorry. Just to say, if you could arrange that, that would be great. Thank you. Okay. Bev, do you have your hand up?
I do, and I just wanted to add on to a lot of it's already been said, particularly around Safeguarding Adults Week, and as well as the adult social care work. There's been work by the partners themselves. We've put out a number of communications around the themes, that because of the daily theme. We have a Safeguarding Bedfordshire website which has its own page for Luton Safeguarding Adults Board. It has a whole host of resources, and also, as you heard earlier, there's the adult social care triax procedures, but there's also the SAB procedures, which talks people through how to apply the procedures, adults in particular circumstances, and as I said, a lot of different resources on there. As part of Safeguarding Adults Week, we've prepared a webinar which talks people through how to navigate the website, how to navigate the procedures, and as well as Safeguarding Adults Week this week, 25th of November begins the Domestic Abuse 16 Days of Action. And as a partnership, we link very closely with the Bedfordshire Domestic Abuse Partnership. What I can do, if it's helpful, is provide links to all those sites. I know that you're going to link in with Jill and Sam and Connor, but just to make sure that everyone's got access to all of the resources that are available to the partnership. And the partnership also does have a training offer. And one of the things will be when we launch and have considerable comms around the shared framework for shared understanding of safeguarding, there will be a range of webinars and different ways to access that. So there's so much work happening in this space. And I have to say that, you know, the strength of the partnership and the willingness of the partnership to support this through resources, funding, but also reciprocal arrangements. It's a real strength that we see here.
Thank you, Bev. Yes, that would be appreciated. Thank you. Okay. Councillor, you had a question?
Yeah, just what my colleague said about the domestic violence and what Jill mentioned about the session. Actually, we really need that information, and we need to know how can we navigate this, because we have lots of residents who are going through that, but we don't know where to and how to. So when you say the police, they did call the police, but they don't want to separate the children from parents, or they don't want their partner to go away, and this is a cultural barrier as well. So we really need that that information. Thanks.
Yeah, more than happy to have.
Thank you. I've just got actually I've got a whole load of questions, but I think they can probably wait. Just one quick question. In your introduction to the reports, Alan, you talk about funding and the fact that it sits disproportionately with the local authority, and you would like to see the strategic partners review the current arrangements to ensure funding is shared more equitably. Could you expand on that?
Yeah, I think we've seen for so long now that the local authority have disproportionately been funding the Safeguarding Adult Board and the Safeguarding Children Board, for that matter. And the amount of additional work that's happened in Luton following the commissioning of Safeguarding Adult reviews, and you'll see in the report the number over the last few years has been quite significant. And they're not, they can cost between sort of £12,000 to £15,000 each time we commission a SAR with an independent author and all the work that goes with that. So that all kind of adds up, and the local authority have sort of taken the brunt of that. It is supposed to be a sort of joint and equal partnership between the key statutory partners, and I think, as in the children's world, it's now mentioned in statutory guidance that it should be shared. Funding should be shared equitably between the statutory partners, and I think that would be a good place to start. And I think the fact that Jill has undertaken the review now, whether that forms part of that review that Jill has commissioned, I'm not sure, but I think it is timely to have a look at that. I mean, it's based on very historic kind of arrangements that were made. There's been no proper funding formula that's there, and you'll see again, I think it's nearly 60% of the funding all comes from the local authority, and it's little bits shared from other partners. So I just think it's timely for that to be reviewed in line with the way it's being reviewed in children's as well. It's a difficult time for everybody because everybody's got no money, and it's probably not a good time to say that. But I've been saying that for some time, and I just think it's important that it gets looked at and gets reviewed.
Jill, do you have anything to add?
Well, just to say we are in the budget setting round, but we would welcome your support to try and get a more equitable arrangement. We're currently at around 50% adults contribution, about 40, just under 40 for ICB and 10% for police. So it isn't an equal share. So if we had your support, that'd be really helpful.
How do other local authorities fund, how are other safeguarding boards funded?
Yeah, I think they've probably all got slightly different arrangements, and often I think it's not just about the funding; it's also about, well, can they provide something in kind instead? And in my view, I don't think that we're receiving that either. So they're not saying, well, we'll give you, the police will chair these different boards, different committees that are part of the board. So it does feel a little bit like it's in our place, and that is part of the review, is to actually to look at all of the types of contributions and real commitments that the partners are making, because just turning up to the board meeting isn't really the whole game, if you like. So that will be part of what we're looking at. It probably won't necessarily look at the funding, but we'll be dovetailing those two things together. But we do have some issues with all of the partners feeling under financial strain, so it's difficult to get any movement. But as Alan pointed out, the local authority does take the burden of that.
And is it the local authority who sets the budget for the safeguarding board?
No, we set it jointly. So we've got an agreed budget for the business unit and for undertaking SARS that we look at together. As I say, it's quite historical, but if we wanted to make changes, have additional staff within that unit or less staff or whatever, that would need to be decision by the board. So it is jointly set, but the contributions have remained static for a long time. And I think safeguarding adults has changed significantly in the last 10 years. And really it hasn't, I don't think the changes have really been reflected in the budget or all of the in-kind commitments as well.
Okay, thank you. That's everything. Yep. Once again, Alan, thank you to everyone involved in producing the report. I think some of us have got actions to follow up on, and just to make sure that any further questions that people have on this report, they're welcome to email them to the appropriate people. Yeah.
Absolutely. Yeah, certainly.
Okay. Thank you very much. Thank you.
Thank you.
Okay, we move on to item 10, the draft work programme. That is looking pretty good shape at the moment. If anyone has any items that they would like to see in the upcoming programme, then please get in touch. We can work it out with Democratic Services to include that. Oh yes, of course, yes. Thank you. Yeah, the January meeting, we will also have the East of England Ambulance Trust on the Bedfordshire EOC potential closure. So we'll have that report as well. Okay. Okay, if there's nothing else, I will call the meeting to a close. Thank you, everyone. Thank you, Amy and Chamber, and thanks everyone who joined.